So it can be used for adult arthroplasty and alignment planning and preparation for knee arthroplasty as well, and post-trauma cases. So in terms of the way forward, the way I approach this, I just go through the basic malalignment test and mechanical axis, and then go through individual segments. And then if there are deformities within each segment, you can then break those down individually. And then, of course, the more complex ones where there's rotational deformities and a bit of all of the above. Key to this is getting good quality imaging so that you can make assessments. And the standard that's been used for a long time is the standing AP X-ray from about 10 feet. And these images are all taken from the resource that was available. I did the Baltimore limb lengthening and limb deformity back in 2004. And I don't think these images, I think they are still available, obviously, and I've found them useful just as a resource to use for consistency as much as anything else. There are other imaging techniques available. We have an EOS scanner, which is a biplanar X-ray scanner, which gives us AP and lateral views at the same time, which is increasingly we are using for our mechanical axis views. But key to planning really is to have a standardized image, which is centered over the knee. But you've got to make sure, ideally, that your patella is facing forward and is consistently in that position so that you can assess rotation and the alignment in a consistent manner. So in terms of the first, you're presented with this X-ray. The first thing you want to know is this a varus? Is there a valgus here? And this would be initially drawn as a line from the center of the femoral head down to the center of the ankle. Now, in the normal aligned limb, this would normally go through somewhere in the middle or just inside the medial side of the middle of the knee. So clearly this is a varus. And then you would need to include a scalar ball of known diameter so that you can use that as a change or a ratio for any measurements. In terms of the nomenclature, then there are small, sort of lower and uppercase letters used for the various descriptions of the angles that we use. And they follow a fairly consistent approach, being mechanical, anatomic, median lateral being uppercase, and then with the proximal distal and then angles being uppercase as well. And what that effectively means that you can describe a mechanical lateral distal femoral angle as the MLDFA. And then similarly, you can do an anatomical medial proximal femoral angle. And finally, just final example, you can do anatomic anterior distal tibial angle as the AADTA. A lot of the time, we're going to be using mechanical axes, but the anatomic and mechanical axes are not the same necessarily in the femur and the tibia. This is probably one of the most important slides. This just gives an example, an idea of what you would expect your normal alignment to be in a mechanical axis view. And the axis of from the center of the femoral head down to the center of the ankle, passing through the center of the knee. This assumes that there's no problems within the knee joint though, and this is something you need to be aware of when you're actually looking at these x-rays. The anatomic angles are different in the femur. The tibia, the anatomic and the mechanical axis are fairly similar, but I think typically they say it's around 2 millimeters different, but they are parallel. So to all intents and purposes, they're used as fairly similar. So in terms of the process, the first thing you want to know is whether or not there is a leg length discrepancy. This typically would actually be from the superior aspect of the acetabulum, again down to the ankle, and then you can look at the differences between the two. You can then look at the individual segments to see whether or not there are differences in the lengths of the femurs and the tibias. And that will give you an indication as to what the length discrepancies are in each individual segment. And then obviously you do the same on the other side. Mechanical axis deviation just gives you an idea of the changes and the deviation of the malalignment. And this will show you from the medial eminences to the mechanical axis line how much deviation you have. And this is a principle that's used quite often in guided growth, just to assess how much change and improvement you are obtaining during the course of treatment. So once you've looked at the malalignment test, you've also just got to try and make sure that there's no problems within the knee joint as well, be it subluxation or whether the knee joint itself is actually open or closed, if you've got laxity or damage to the individual joints. The individual segments can then be analysed to see where actually the varus or valgus is occurring. And taking us back to that main alignment slide, the mechanical femoral, lateral distal femoral angle is usually around 87, 88 degrees or therefore thereabouts. So anything less than that would be a valgus, anything more than that would be varus. Tibia, typically it's about 88 degrees or almost 90, give or take. And that would be passing, the axis would pass directly down the center of the tibia in the normal instance. But as I mentioned before, just be careful that you look at the joint itself, because the joint congruency can actually be non-parallel, and you just need to be aware of that, because that can introduce intra-articular changes to the overall alignment. Also be careful that there's no translation of the femur and tibia relative to each other. When you have changes within the actual articular surfaces themselves, we quite often see this post-meningitis, and you can see that the condyles not necessarily parallel, and they can also, in terms of Blount's and other conditions, they are not going to be similar, and you need to take this into account when you're doing your individual segment analysis in terms of what you're going to correct. So if we just look at a individual uniapical deformity, we would typically draw our reference lines across the joints proximally and distally, and then draw your axes that would be seen in the normal bone, and where they intersect would be the chora, or the center of rotation of angulation, and this will be the point around which you need to move or make the osteotomy in order to straighten and correct the malalignment. That intersection can be bisected, and there are various concepts around this. Most of the time, the Rule 1 osteotomy, where you actually pass through the angulation and the bisector line, you won't get any translation. When you start deviating from the bisector line, moving proximally or distally, or off the bisector, moving it away, you will introduce translation and rotate. You can put your hinge point anywhere on the bisector line, and it will actually give you a corrected alignment at the end of your procedure. And you can set it so you can either have an opening or closing wedge, depending on whether you want length or not as part of your correction. But if you start moving your hinge point away, you can introduce a translation, and you can use this almost usually in a reverse way in order to correct what you actually want to achieve, depending on the malalignment or the deformities that you have presented to you. So, for example, with this case, we've done the mechanical axis view. It shows that there's a deviation of medial varus. We then want to say, well, whereabouts is that occurring? So if we do our segmental analysis of the femur, that's measured at 71 degrees. So there's a significant valgus within the femur. However, overall, there's a varus in the entire lower limb. So we then need to carry on and actually just check the tibia as well. So we draw reference lines and draw the normal axis line that you would expect in the proximal tibia. Go down to the ankle and then draw the normal axis reference line. And that crosses outside the tibia. Now, if you wanted to, you could draw your bisector line through that, osteotomize the tibia, and if you corrected around that bisector line, you would get a mechanical axis of the tibia such that the ankle and the knee joint are parallel, and they would be aligned in terms of the joints, but you would have a very Z-shaped tibia in the middle. So clearly we can't really do that because we want the axis, mechanical and anatomic axis, from the knee joint down to the ankle joint to go through the bone at all times. So what we then do is find a point on those axes lines where they are about in the middle of the medullary cavity of that bone. And we draw that line down through the bone. And where we join the axes lines with that middle line, that gives us a biplanar correction that's necessary. So you can then have two separate osteotomies, which will then correct the overall malalignment and straighten that individual tibia. So this is just going back to the first rule, just giving an idea that we've drawn our bisector line, and by correcting on that, we straighten and correct the tibia. If we move away on the bisector line, then we introduce an amount of lengthening, but we still correct and don't translate that tibial deformity so that we maintain the overall axis and the alignment. But with this multi-apical deformity, if we did our hinge point, we could straighten and make our ankle and tibial alignment of the joints parallel, but we would have this very abnormal and bent tibia at the end of that procedure. So what we then have to do is actually go and look at this in a different way. We draw that bisector line down the middle, and then we do a proximal osteotomy, and we correct the proximal alignment so that we get the axis from the center of the knee down the tibia. However, we still don't have a properly aligned ankle joint compared to the knee joint. So then we go down to our lower end and do the same again and correct that. At the end of those two procedures, proximally and distally, we will have a corrected tibial mechanical axis, but we will also have both the ankle and the tibia parallel. This is just one example of using these principles, and this was a hip replacement that was put in a little bit too tight and incorrectly. If we look at the axis and work out the neck shaft angle, that angle there should be 90 degrees. It was put in a bit long so that the proximal angle is too great. It's about 9 or 10 degrees too high. And this probably had something to do with the fact that this hip then dislocated because it was a bit too tight and long. And this is really an example to show that you don't have to use these principles just for pediatric cases. Just be aware of the proper planning that you can use, and then arrange for you can then correct them using the same principles. You don't have to use fixators. You can do acute corrections in the femur, but again, the same principles apply. This is just something that I keep going on about. When you look at an X-ray, you just need to be aware that it is a two-dimensional picture of a three-dimensional object. And by rotating the individual bone, you can project an image of either it looking completely straight or the malalignment, as you can see. So this is why it's so important to have standardized images. And if I can just show that this, if you imagine this as a neck shaft angle, if you externally rotated the femur, you could have a measured neck shaft angle of anywhere between 135 and 180 degrees, all just depending on the rotation of the individual of that femoral segment. I realize this is just a little multi-tool, just showing the basic principle. But just be aware of the rotational projection of your bone on the X-ray when you're actually analyzing these images. There are lots of other things that, in terms of oblique plane deformities, that we can go through, but I think in terms of time, those are the basic principles that I would suggest in terms of the mechanical axis deviation and the individual segmental analysis, and then the basics of the osteotomies and the corrections